Welcome to the Brain and Mind Institute's webinar on mental health in diverse regions, global challenges, and local solutions. This topic is very timely and has provoked a lot of interest. We have uh, commemorating the World Mental Health Day. And on our last count, it has triggered a lot of interest. We have had about 1,200 registrants worldwide and people joining us from Kenya, Tanzania, Uganda, Pakistan, Afghanistan, US, Ethiopia, Canada, Ghana, Somalia, Rwanda, Burundi. So as you can see that there is a lot of interest in this topic, and we have very exciting panelists who I'd like to thank for joining us. So welcome each and every one of you. We are so delighted that you have set aside time and made mental health discussions your priority for today. I am Zul Morali, as Gloria said, the founding director of the Brain and Mind Institute. And the Brain and Mind Institute is a young institute at the Aga Khan University. And with the focus on brain health and mental health. We have two hubs, physical. We have one in Nairobi that we're speaking from that serves Kenya, Uganda, Tanzania. And the other one is in Karachi, which serves in Pakistan, serving South and Central Asia, where Murad is right now. We work across, the Brain and Mind Institute works across four platforms. One is, of course, research, because we're a research institute, but we focus a lot on innovation, implementation, translating research to care. How do we enhance the access and delivery of mental health care in the communities? We have a platform on education, which is public facing. So we develop courses for people who may not have all the background necessary, but prepare them. And then finally, partnerships, because our philosophy is to create a big tent to bring people interested into our fold so that we can all work together. So we got a lot of partners. Our research focus is on three thematic streams. One is on depression and suicide prevention. The other is on brain aging with a focus on dementia. And finally, family violence and substance use are also areas of interest for us. You can learn more about the Brain and Mind Institute from our website. So without further ado, let me start by introducing our esteemed panelists. First of all, I introduce Dr. Professor Murad Khan. He's a suicide prevention and mental health expert at the Brain and Mind Institute. Dr. Murad Khan leads the suicide and prevention strategy at the Institute, and is focusing on suicide, depression, implementation science to enhance mental health practices. He holds a PhD from the University of London and is a professor emeritus at the Aga Khan University. Dr. Khan is being closely involved with international associations, particularly Association for the Suicide Prevention, IASP, where he was the president from 2017 to 2020. He continues to contribute to them as being a member on their board. His research addresses epidemiology, sociocultural factors associated with suicide and self-harm, particularly in South and Central Asia and other developing countries. So thank you. So our next panelist is Dr. Chido Rajwa Maja Moje, who is a regional advisor for mental health in African regions for the World Health Organization. Dr. Chido serves as the WHO regional advisor for mental health in African regions and is a consultant psychiatrist with expertise in public mental health. Her role is that she leads WHO's mental health strategy across the region, working in countries to develop policy and frameworks that improve mental health access, treatment, and awareness. Our efforts include addressing barriers to care, integrating mental health services into a broader health systems, and promoting mental health and literacy at individual, at family, at community and organizational and policy levels. Dr. Chido's work at the World Health Organization also involves supporting national health ministries to implement mental health initiatives that align with the global best practices and regional needs. She has contributed to the initiatives aimed at reducing stigma, increasing the availability of mental health services, and improving training for health workers on mental health care and advocacy. So, as you can see, our panelists are experts and bring a lot of um, expertise in mental health to you today for discussion. And so, without further ado, I'm going to invite Dr. Chido to give you a brief presentation, and then that'll be followed by a presentation by Dr. Murad Khan, and then we'll go into a moderated a question answer session. So, can we begin with you, Chido?
Thank you so much, Zul, for the kind introduction, and also for the invitation to participate in this webinar in commemoration of World Mental Health Day. And I think it's illustrative of what we should be doing, that World Mental Health Day is not about the 10th of October only, but throughout the year. This should be something that we should be thinking about and keeping it front and center in our minds. So I will be sharing on mental, neurological, and substance use in the African region, and just giving a brief overview of some of the challenges, but also some of the achievements that we've had. So I'll cover a brief introduction. We'll talk about some of the critical challenges, the key achievements, the strategic direction, our strategic priorities in the region, as well as some of the interventions that we could be thinking about given the unique challenges we face. Mental health is a critical part of health and well-being, and it's a basic human right. And mental health enables us to reach our full potential, to cope with life challenges, work productively, and contribute meaningfully to our communities. And as you know, that's the definition, the WHO definition of mental health. The conditions that affect our mental well-being affect 1 in 8 people worldwide, but 6% of the total disease burden in Africa, with depression contributing to over 600 disability-adjusted life years. Anxiety following close behind that, then alcohol, and as well as drug use disorders, as illustrated in the slide. One very worrying statistic is the suicide rate in Africa, which is the highest amongst all the WHO regions, at 11.2 per 100,000, compared to 9 per 100,000, which is the global rate. So it's a big worry, and it's a very high rate of male suicides at 18 per 100,000 of male suicides within the region, again, the highest in the world. And however, all this data is also quite sparse because only 11% of African region countries routinely collect mental health specific data in their health information systems. So this has been some of the challenges, and the response to the mental health burden has generally been slow. Mental health is, however, a key part of the Sustainable Development Goals. If we remember, SDG 3.4 talks about reducing by 2030 by 1/3 premature deaths from non-communicable diseases, and this includes mental health. And we actually track an indicator there, which is suicide mortality rate, to see how we're doing with that. And then SDG 3.5, which talks about substance use, and we aim to also strengthen and prevent substance use challenges and improve access to treatment. And we look at service coverage and also reduction of harmful use of alcohol. What are some of the critical challenges we're facing in the region? I've already mentioned that very high suicide rate, but also stigma, discrimination, lack of awareness about mental health challenges. 49% of African region countries don't have a mental health awareness program. This is data as of 2020 when we did the mental health Atlas survey. We're currently collecting data for 2024, so we'll have more recent data, but this is what we have as of 2024. That's half of countries that are not actually having a structured awareness program. Then in terms of preparedness for emergencies, and Africa faces a number of emergencies, humanitarian emergencies, emergencies due to infectious diseases. However, only 28% of African region countries have integrated mental health and psychosocial support into their disaster preparedness plans. Additionally, there's limited integration of mental health into primary health care. Only 13% of countries have what we call functional mental health integration, which includes not only guidance for how we integrate mental health into primary care, but also having training for primary healthcare workers in how mental health should be managed at that level, having support and supervision, having medications available at primary care, as well as psychosocial interventions. There are gaps in data. We have challenges in terms of routine data being collected, but also we have challenges in terms of research output. Only 2% of all the research output globally was coming from Afro as of 2020. Then issues around money and financing. So the structured financial investment in mental health. So the biggest challenge is per capita government expenditure for mental health, which is at 50 cents per capita as of 2020 compared to $7.50 globally. And if you think about that, even if you look at it as what governments are spending as part of their total government expenditure. 38% of countries were spending 5% or less in terms of total government expenditure on mental health. So these are some of the challenges, and of course the outdated legal and policy frameworks. A lot of countries have improved and are working on this, but only 32% of mental health laws have been developed or reviewed in the last 10 years. Some of the achievements, it's not all doom and gloom. There are significant achievements we need to highlight. The suicide rate has actually been coming down, and it is now at 11.2, down from 14.2 back in 2014. That's about 10 years ago now. And compliance of our mental health policies with international human rights instruments is up to 68%, up from 41% in 2014. The health workforce, the specialist health workforce, has improved slightly from 1.4 to 1.6 per 100,000, but that's still a drop in the ocean in terms of what we need of mental health workers. In terms of training of primary healthcare workers, 79% of Afro-region countries are currently having some form of primary healthcare worker training in mental health care, which is encouraging. I think I've already mentioned the issue of per capita spending, but it has come up as much as it's still a challenge at 46 cents per capita. It's up from 10 cents, which it was in 2014. And then the mental health psychosocial support we only started measuring that in 2020, and we're hoping this has improved. The region has a strategic framework that member countries endorsed in 2022, and this is what guides the work for mental health in the region. And we look to strengthening effective leadership, governance, and financing, and looking specifically at legislative and policy reform. Also advocating for dedicated budget lines for mental health that gives structured, predictable financing towards mental health programs within countries. And then, of course, inclusion of mental health, neurological, and substance use in national health insurance plans. We also are supporting countries to increase coverage to quality mental health services with a focus on decentralizing care to primary and community level. And this also means task shifting from specialists to non-specialists and ensuring that there's effective mentorship, support, and supervision. Then we're also working to increase the specialist health workforce with a focus on equitable geographic distribution. A lot of the times, the specialist mental health the service providers will only be in the big cities and not in the more rural settings. And then improving our data, really sharpening our data systems to be able to capture the burden, but also the impact of any interventions that are coming in. And then strengthening the focus on prevention as well. We're now aware that there's so many social determinants to mental health, things like social networks, healthier lifestyles, economic empowerment, that can really improve the mental health outcome. Those are some of the other global guidance documents that also shape work within the region, just highlighting that WHA, the World Health Assembly resolution that was passed this year on strengthening mental health and psychosocial support before during and after armed conflicts, natural and human-caused disasters. This was endorsed by member states earlier this year. Where are we wanting to go? So if we look at some of these things that I indicated in the regional framework, things like governance, 74% of African region countries have a mental health policy. That was 2020. We're hoping that this will have improved to 80% by next year. And then hopefully all countries will have a mental health policy or strategy, either standalone or integrated into other health plans within the countries. Then mental health financing, we're hoping that will improve as well. Currently at 38% of countries with some allocation, improving hopefully to 60% by next year and 70% by 2030. Then also looking at mental health integration. So that functional integration that I mentioned, hopefully this will be up from 13% to 30% by next year, and then 80% by 2030. And then also our research and information systems, we're hoping that about 60% of countries will be routinely reporting on mental health, neurological and substance use by next year, and hopefully close to 100% by 2030. Again, where do we want to go? We need to raise the profile of mental health, and this is webinars like this are part of it. This helps to fight stigma. It increases awareness about what the problems are and what we can do, and very much importantly, to also include people with lived experience, which we know humanizes the conditions, humanizes the whole situation, and it helps to fight stigma. It's one of the most effective ways of fighting stigma. We need to decentralize, which I've already highlighted, and integrate mental health. It will take us a long time to get the number of mental health specialists that we need. So there's a need to decentralize, mainstream our mental health skills so that all healthcare workers and social care workers have got mental health skills and can help people at community level, primary care level as well. We need to prepare for crisis. That mental health psychosocial support, very, very important in terms of disaster preparedness and response. And we need structured investment, structured financial investment, as well as policy reform so that our laws, our policies, our strategies are in line with human rights expectations. I've already mentioned the psychosocial risks and thinking about prevention and how we can work across the society, have that whole of society approach to mental health so that it's not a health issue, it's a society issue. And it can be addressed from many angles. And also we need to improve our data. It's very difficult to drive for investment if our data is not up to scratch. And that's something that we need to strengthen in the region. Strategic investments, because we've got limited resources, got limited financial resources, limited human resources, the WHO has an optimal mix of what mental health can look like. We need to support self-care, awareness about mental health, knowing when to get help, mental health literacy. All of these are very, very important as the base of care. Most people will be able to get care at that level and at community care. Of course, self-care is throughout the health system because you are supposed to continue practicing self-care, even if you're needing higher levels of support. Then, of course, our primary care, which I mentioned, we need to integrate mental health into primary care. Very critical that mental health is integrated into clinics, into local primary care facilities, and is available. And where people need help, we have the stepped care approach to say someone who cannot be managed at primary care can then be moved up to secondary care in psychiatric services within general hospitals or community care facilities. And only those needing very specialist care then end up in our psychiatric units. The aim being to actually decrease and eventually even close many of these long-stay facilities where we know that a lot of human rights abuses can occur. So these are some of these strategic interventions that we can think about looking at our setting in Africa and making sure that we have appropriate services. So I think I'll stop there and hand over back to you, So. Thank you.
Thank you. Thank you very much, Chido. It's such a lot of information that's so critically important for us to understand. And thank you for bringing our understanding more up to date. And we will, of course, have a lot of opportunity to ask you some questions about your presentation and the topic in general. But let me first move to Dr. Murad Khan and have him share what his thoughts are about depression and suicide in the Global South.
about strategic priorities apply not only to Africa, but to all regions of the world, including the South and Central Asian regions that I'm going to be talking about. I'm going to give you an overview of suicide prevention and mental health in Central and South Asia from perhaps a slightly different perspective than the one that Dr. Chidu had just presented on. So for those of you who are not very familiar with the geography, this is the region of the South and Central Asia. There are about 7 countries in South Asia, 8 if you include Maldives, and 5 in Central Asia, which is not very well known about. So there are countries Kazakhstan, Kyrgyzstan, Turkmenistan, Tajikistan, and Uzbekistan. And then in South Asia, we start from Afghanistan, come down to Pakistan, India, Sri Lanka, Bangladesh, Nepal, Bhutan, and Maldives, which are a group of tiny islands in the Indian Ocean. Collectively, they have more than 22 billion population, mostly by the mega country of India, which has about 1.4, 1.5 billion people currently. And we share a lot of cultural and social um, factors in South Asia, as do the countries in the Central Asia do. So if you look at South Asia, the burden of psychiatric disorders, the global burden contribution is anything between 4.4 to 13.4. Of these conditions, depression, anxiety, substance abuse, and psychotic disorders like schizophrenia really stand out. What is interesting is the global burden of disease contribution by women is much higher than that of men in South Asia. The prevalence of psychiatric disorders varies from 12.2 to 14.2, and if you convert that into real figures of um, uh, population, then we are talking of really millions of people who require mental health care. It is estimated that the number of psychiatric patients in this region in South Asia are more than 200 million, which is a huge number, which will challenge any health system. But more worryingly, there is a huge treatment gap. Treatment gap means that the number of people who require treatment and the number of people who are not getting it. So the treatment in South Asia overall is about 85%, which means that people with mental health problems, 85% of them are not getting proper, regular, quality mental health care. In Bangladesh, it is more than 90%. In India, it is between 85 to 95%. In Afghanistan, it says 70%, but I doubt it very much given the conditions in Afghanistan. It's probably much higher. So if you look at the prevalence of common mental disorders, and common mental disorders means mild to moderate degrees of depression, anxiety, and related disorders, excluding psychotic disorders. They are quite high, as you can see. And again, if you translate these figures into raw numbers, then we are again talking of millions of people. When we come to suicide rates, generally, South Asia contributes about 30% of the global suicides of about 700,000 that currently happens around the globe. And the majority of these suicides are from India. The number here is 173,000, more than 173,000. However, many of the suicides are misclassified and undercounted, and the true number in India is closer to 200,000 suicides, 0.2 million per year. The age standardized rate, that is ASR, in India is 12.9. The average global suicide rate is around 9 per 100,000. Both in men and in women, India has one of the highest suicide rates. If you look at the last column where it says M is to W ratio, which is men to women ratio, it is much narrower. Usually around the world, more men than women kill themselves. Men outnumber women about 2 to 3 to 1. But in India, the gap is much narrower, as it is in Afghanistan. And it tells you the psychological morbidity and the suicidal behavior in women in these countries. Pakistan is contributing around 20,000 suicides per year, with rates of men which is very close to India. Sri Lanka, whose rates have come down from used to be in the 40s, in the 70s and the 80s, it has come down to 12.9, but nevertheless still remains quite high. The overall picture here is that suicide is a major problem in South Asia. It is a major problem with both men and women. And the other point I want to make is, apart from perhaps India and Sri Lanka, most of the other numbers that you're seeing here are based on WHO modeling. So none of these countries collect good data, good quality data on which we can then build strategies, prevention strategies, and inform policy. So this is a major weakness of this data. Next slide is the suicide in South Asian women. While overall suicide rates and rates in men are highest in Africa, the highest number of women and the highest rates of suicide in women globally is in South Asia or Southeast Asia. And if you further disaggregate the data of women's suicide, what is again very striking is there are more married women than single women in suicide statistics in South Asia. So these are 4 countries where data is available, which present data disaggregated for gender and marital status. Not all studies do that, so it's really difficult to tease that out. But you can see in all of these studies, married women outnumber single women in suicides. And so the point that seems to be emerging is that unlike the West, where marriage or being in a relationship is protective against psychological morbidity and psychiatric disorders and suicidal behavior, marriage in South Asian cultures appear to be a significant risk factor, both for psychological morbidity and suicidal behavior. So any prevention strategy must take this into account, and there are various reasons behind the high psychological morbidity and suicidal behavior in married women, and I should add young married women. And we need to look at the factors and then to see how we can address those factors. And there are a host of factors behind that, which hopefully might come in the discussion. I will now turn to Central Asia, which we know very little about. It was really difficult to get these figures. And again, these are based on a mixture of some estimates, modeling, as well as some surveys that have been done. But you can see both depression and anxiety, it's anything between 2% to 4% for all of these countries in Central Asia. If you look at the suicide rates in these countries, you can see in some of these countries, suicide rates are actually quite high. In Kazakhstan, for example, it's 18.1 per 100,000. And then men's suicide is probably one of the highest in the world at just under 31 per 100,000. But also in women, it's 6.9. Now, all these countries are the former Soviet Union republics. One of the problems that was happening in the former Soviet Union was very high degree of alcoholism. And we know that alcohol is a very strong mediator in the societal process. Although they have become independent and they have a different system now, the problem for alcoholism still continues. And so the rates, although they have come down, have again kind of rising in some of these republics. Next slide. Savani and colleagues did a study looking at suicide in Central Asia. They looked at some of the risk and protective factors, and they came up in the risk factors 5 main domains, which are not very different from what you would find in other developing countries or low and middle income countries. That is depression, alcohol, abuse of by males on the females, low education level, unemployment, and so on. So these were the risk factors. And if you look at the protective factors, then it is a good support system, employment, higher education, and so on. So these are, again, very important issues to consider when devising. In South Asia, the challenges are not very dissimilar, but there are few challenges that my colleague Yasser Arafat from Bangladesh and Sujita Kaur from India have highlighted in this book, Access to Mental Health Care in South Asia. They have also highlighted things like political instability and war and terrorism. And this is very important because both direct as well as indirect effect of the political instability that we find in South Asia, as well as wars and the trauma that occurs as a result of that, have a major impact on people's psychological health. Some of it then gets converted into societal behavior. However, it's not all doom and gloom, and there's some really good developments that are taking place in South Asian region. In Sri Lanka, for example, they had a very forward-looking pesticide regulation policy where they banned a lot of these class 1 pesticides. As a result of that, suicide rates in Sri Lanka have come down, and it's a very good model of how to regulate through policy certain methods that can have a huge impact on suicide rates. In Pakistan, a number of web-based apps have been developed based on the WHO's MHGAP and MHPSS programs. One of our colleagues at the Brain and Mind Institute has developed a program which is called Emparishan, which is also a web-based program and an app through which you can screen for psychological morbidity, common mental disorders, and then to do basic counseling and refer the others. In Nepal, the mental health policy strategy and action plan in 2020 was developed, which has made a huge impact in Nepal. And in Afghanistan, despite the fact that they have had, more than 4 decades of war, a national mental health strategy was developed for 2009 to 2014. Of course, things have changed dramatically in Afghanistan, but at least they have a foundation and template on which to build on. In India, they have a community-based mental health program called Atmiyata. This is a stepped care model that the Brain and Mind Institute is also working on. So Atmiyata is a low-cost, high-impact, sustainable, and scalable model. And it is not a standalone, but it kind of complements the public health mental health system of India. And the idea is to reduce the care gap for people with mental health conditions. As far as suicide prevention is concerned, the International Association for Suicide Prevention has come up with this program called Partnerships for Life, or P4L, which has divided the regions into the WHO regions and is looking at suicide prevention in different regions rather than globally. The idea is that regions have more commonalities, and if you can break it down into smaller regions, then perhaps the suicide prevention approach would be more effective. All of these things can be seen on the website. So some last slide is this one. So challenges and opportunities. I think it's very important to have regional cooperation. And so we should look at South-South collaboration while we keep working on the North-South collaboration, but we need to learn from each other because countries in the South have common issues of poverty, of unemployment, possibly political instability, and so on. And so within that environment, how do we address these challenges? And that's where we can learn much more from each other. It's very important to address the social determinants of health and mental health. Suicide or mental health is not just an individual or a health issue. It is a societal issue. And we need to look at what is now called whole of government or whole of society approach and a public health approach to suicide prevention and mental health. And poverty is one of the most important things that needs to be addressed. We need to look at local models of care rather than to import care models that have worked elsewhere, particularly in the West. We cannot have cognitive behavior therapy, which has worked for patients who are suicidal in high-income countries because the health system is very different, and then to just adapt it to our population. We need to listen to the people with lived experience, and use the experience to inform our programs. We don't have good mental services, but we do have a very strong family system, and it is important this family system is supported and strengthened both materially, financially, as well as emotionally. We need really good surveillance systems. We don't have that. Um, with the surveillance system, we will be able to generate data, real-time data, on which we can then take action. We need research that is focused, that is relevant, that answers some of the questions that our countries are struggling with. Now, the problem here is if you apply for research grants, then most of the research granting agencies are based in the West, and they have their own agendas, and they will fund a certain type of research. So the question that we as researchers, when we are writing a grant, we always ask ourselves, maybe NIH will, let's write this because NIH tends to fund this, or the Wellcome Trust tends to fund this, so let's put that in, rather than what our needs are. So we got to really think very carefully of how do we move away from reliance on funding from these countries that have their own priorities and look for funding in our own settings. And it's a dialogue that I think is long overdue. We need national strategies, both for mental health, for suicide prevention, which should include all stakeholders across the board, and not only by the experts or the academics, but from across the board, particularly from people with lived experience. And so we should come up with models that are locally embedded, that are informed by local knowledge and local wisdom. And only then I think we'll be able to address some of these issues that we're faced with. So I'll stop there. So thank you very much.
Thank you, Murad, very much for your presentation and talking about some of the challenges as well as potential solutions going forward. I think it's important also to figure out how we can have information exchange, as you were saying, across Global South, because we share many of commonalities that we can kind of address together, because we have adopted a lot of practices and concepts from the Global North. Not that it's not useful, but I think it sometimes is not contextualized enough to be effective in our geography. So it's very important that we learn from each other and really enhance the well-being of the populations in the Global South. So with that, I'm now going to move into a question answer session, and I'll start out by maybe asking Chido, uh, the fact that World Health Organization Africa has kind of promoted a lot of community-based mental health care. And I was wondering whether you might be able to share some promising examples of how these initiatives, what they are, and how they can be scaled up to reach many more people across Africa and then the global south.
Thanks. So, and yes, community-based care, that pyramid that I showed with the optimal mix is really the base of the pyramid. So we expect if we promote that, most people should be able to get a lot of their mental health care needs and even their other healthcare needs met in their community or close to their community. This is more acceptable, this is more cost effective, and also within the mental health space, it's more amenable to ensuring a rights-based approach and a person-centered approach if someone is managed in their community. And generally, some of these community-based services include crisis intervention services, community health centers, but also peer support groups and service user networks, as well as community outreach services. So some examples of peer support is the users and survivors of psychiatry in Kenya. This was highlighted within the WHO guidance on community mental health services, which is available online. I'll share the link. It was one of the organizations that was highlighted. It's a national member-based organization that encourages formation of peer support groups for people living with psychosocial disability and mental health conditions, providing support, but also advocating for the rights and the needs of people living with mental health conditions. This allows for people with lived experience to speak into policy, to speak into how services are arranged, and really empower them. Another example is the Friendship Bench in Zimbabwe, which is a community mental health outreach service delivered by lay health workers. Lay health workers in that setting are generally older women, average age of 58, settled in the community, but also trusted in the community. And remember that something that Murad mentioned, that local wisdom. And then they are trained then in basic counseling skills, knowing how to screen for common mental health problems, knowing how to actually then deliver some treatment in terms of problem-solving therapy for mild depression, and then knowing when to refer the more moderate and severe conditions to the clinic. And again, local wisdom, acceptable, appropriate services that are close to the community, that are answering the needs and of that community.
Thank you, Chido. I'll ask you one more question and then I'll shift to Dr. Murad Khan. So the other question I had for you was that the World Health Organization is addressing mental health stigma across Africa, or at least attempting to. What strategies are proven to be effective in shifting the public perceptions and particularly in encouraging people to seek help when they need?
Indeed, stigma is still a big challenge, and it's one of the barriers to people even knowing enough about mental health problems, seeking help. And even when they are seeking that help, they can face discrimination, issues around return to work. So these are there are quite a few challenges. So the Lancet Commission on Ending Stigma and Discrimination in Mental Health, that was done in conjunction with WHO in 2022, recommended a few things. One of the major ones is including people with lived experience. So social contact between someone who has no lived experience of mental health conditions and someone who does reduces stigma. So it just humanizes the whole situation. You can discriminate and talk about or talk badly about someone that you don't know. Once you get to know them and realize they're a human being just like me, they're suffering, and I suffer in other ways, and their health conditions, I might have a different health condition, but we're both struggling with it. It humanizes it. So creating opportunities for that social contact, but and working with people with lived experience is very, very important in reducing stigma. But also including people with lived experience throughout the health system, whether it's policy development, whether it's service development, service monitoring of the service, and this there's a statement that says nothing about us without us, and it's important to include people with lived experience in those services so that they become more appropriate and that people start to interact with people with lived experience and again the social contact. There's also issues around decriminalizing suicide. So there are policies that are still very much out of what is expected by international human rights standards, and criminalizing suicide, things like that. We're encouraging countries to decriminalize, and a number of countries have actually made that step. This also works to reduce stigma. Issues around reasonable accommodations at work. So when someone struggles with a mental health condition, they may have to take some time off work. When they come back, there might be need for return to work programs and reasonable accommodations. This also reduces stigma. It makes it possible for someone to come back to work, and for everybody within the workspace, return to work setting, to understand that they might have had a challenge, but they can work. They can be productive. They can be part of our community, and to encourage that. And then, of course, working with the media. So the media is one of the most powerful tool in terms of changing perceptions. And that's something that we've been actively working to do. We've done media trainings with our regional journalists and media houses to understand mental health better, to report in a safer way, particularly about suicide, because we know that if suicide is reported in a particular way, you can get a lot of copycat suicides after that in that same community. So just that responsibility to report on mental health, but just awareness of the media, so that their stories are also helping to raise awareness and point people towards where they can get help if they need it. I'll stop there. Thanks.
Thank you. That's very useful and eye-opening for us to have this conversation. I'm now going to shift to Dr. Murad Khan. Murad, you pointed out that in South Asia has very high suicide rates, especially amongst the youth. And what social and cultural factors do you think contribute to this? And what culturally sensitive interventions do you think might help us make a difference?
Thank you, Zul. So most of the South Asian countries have a very high youth population. So more than 50% of the population in countries like India and Pakistan are below the age of 30 years. Now, youth is a time where people are completing their education and then stepping onto professional lives. And what young people are seeing in front of them is a future that does not look so rosy. And the reasons for that is beyond, the health sphere. So there are political reasons, there are social reasons, societal reasons. There is a lot of despondency. There's a lot of despair. When they look into the wider society, they don't see much hope. In Pakistan, for example, over the last year or so, hundreds and thousands of young people have left the country. And these are, people who are able to go abroad legally, are people who are very skilled, who are very educated. So it's a huge brain drain. So young people are finding this, and we've seen the upheaval in Sri Lanka. We've seen the upheaval in Bangladesh, and these are led by young people because young people are not happy with what is happening in their countries, and it's the same thing in Pakistan. So this all gets translated into all sorts of behaviors, drug abuse, for example, reckless behavior, violence. Some of it then spills over into psychological conditions, depression, anxiety, and so on. And then some of this then gets translated into societal behavior because at that point, other factors like genetic factors, for example, support system and comorbidities from, say, drugs or alcohol and violence and so on come into play. So that is generally, but when you break down into women, young women, for example, that I touched upon in my presentation, again, young women are in South Asia in particular. They have a very difficult time. They lack empowerment. They lack agency. The average age of marriage is very young. Um, the economic dependence on the husbands, and then after marriage, there's a huge problem of domestic violence, interpersonal violence. So young people, on the whole, both men and women, although some of them both are facing common problems, but they're also facing some particular problems due to gender. And I mention these because prevention strategies must really address these things. We can't have 50% of people in Pakistan living under and around the poverty line and expect them to be happy. We can't do that. So we need to have policies, upstream factors that can address the real issues of the people of our countries.
Thank you, Murad. Very, very wise reflection. I'm now going to turn to some of the questions that are coming in from the participants. And so this is a question for you, Chido, is when can we anticipate the World Health Organization to release guidelines on taxing major tech companies such as Facebook and Twitter, as well as gambling firms, given their impact on worsening mental health?
Thanks, Zoe, for this, and thank you for the question. Pertinent question, but just to say that WHO supports member state governments, ministries of health. So this is a question that needs to be answered at member state level. And yes, there is evidence that social media has detrimental effects on, or excessive use and irresponsible use of social media has detrimental effects on mental health, and gambling, I think, has also been included even in the diagnostic statistical manual as something that is definitely a challenge. So I would say this needs to be handled at the member state level, and it's good to lobby for some sort of management of it. However, when we think about things like social media, it's very similar to something like alcohol. Sometimes it's also creating and giving young people the tools that they need to use that tool in a responsible way. It's very unlikely that we'll be able to eliminate technology from the lives of our children and young people who are most affected by it. But if we can teach them and give them life skills and build resilience into them as they are younger, they can then use these tools in a responsible way, and they will be less likely to have the challenges that are faced there. But I'll say it has to come at a member state level in terms of any legislation.
Thank you. Thank you. Chido, now I'm going to take a question which I think is pertinent for Murad to answer, and that is there any data that shows linkage between having children versus infertility that link with suicide, and particularly for married women?
Yes, there is some data that has looked at psychological morbidity in women who are infertile, but the linkage between infertility and suicide, at least for Pakistan, as far as I know, is not available. But it's a very good area to research. There is data from other countries, but again, it's missing from Pakistan. And if the person who's asked the question is interested, certainly can do this piece of research.
Thank you. So, Chido, there's another question that asks from the panel, from the participants, is that in rural or remote areas where mental health services are scarce, what alternative models for suicide prevention can be implemented effectively?
Okay, thank you. So suicide really is not and I think Murad alluded to this. It's a whole of society approach if we're really going to prevent suicide. So it's not an issue of the lack of health services only, but all the other issues that we need to address. The most effective ways that have been seen, and these are part of the WHO Live Life public health approach to suicide prevention, and I'll share the link on that so you can get more details about it, is limiting the access to means for suicide. So many times pesticides, highly hazardous pesticides, are part of this. And too many times in many countries, many settings, they're too easily available. So suicide is something that often happens in a moment of crisis, in a moment where someone feels overwhelmed, and then they reach for the most poisonous thing that they can think of. And if that is not available, then you will have less deaths by pesticides and highly hazardous pesticides. So that's something that can actually be done, which is actually beyond the health system, which can bring down these deaths by suicide. Again, issues around the media and how communities communicate about suicide, raising awareness about that there are mental health factors that can lead to suicide, and that people actually need to get care and support prior to these crises, can help to change the attitude and perspective about it, that it's partly a health challenge, it's a psychosocial challenge that can be addressed, and reducing those risks. Also making sure then that the primary care, the few healthcare workers that are available, know how to manage the common mental health conditions. So they've been trained in things like MHGAP, and MHGAP includes a module on suicide prevention, and they can be able to attend to someone who might be having these thoughts. But again, awareness is very important, that if someone has these thoughts, they know, let me go to the clinic and talk to them about it. So those are just some of the public health approaches as well that can be done at community level. Thank you.
Thank you. So another question from the participants is that could you, and this is for Murad maybe, could you provide insights into the mental health issues, example, suicidal or self-harm effects affecting children and adolescents, particularly in Southeast Asia region? So I think you talked a bit about it before, but I guess if there's additional information that you might be able to convey to this participant.
I mean, suicidal behavior is really unusual or very rare in children under the age of 10 years. It's only 10 to 12 years and beyond that people start thinking in those terms, because the thinking is much more developed and they're able to perceive things in a different way. what really needs to happen to prevent suicidal behavior in young people in particular, I'm talking of young people, say 15 years or less, is to, as far as possible, to provide them with as healthy and as safe and as warm an environment as possible. And that brings into question the parenting styles and the stress that is there on the parents themselves. If a father is unemployed, he or she would be under a lot of stress. In South Asian communities, a male's main job is to provide for the family. If he's not able to do so, the stress on him is tremendous. Now, to deal with the stress, he can drink, he can use drugs, or he can also become violent towards the wife. Now, that has a very bad impact on the children when they witness violence in their own homes. So again, the issue comes around to the social determinants and what can we do to support people who find themselves in that precarious situation. So young people are obviously exposed to that. And then there are obviously many other issues, peer pressure, for example, academic stress, and so on and so forth. But as long as the primary relationship that they have with the parents, that is good, that is warm, any stress that they may find themselves in, they will be able to come and discuss and get some help. So that is where the focus should be, on developing that relationship between the child and the parent. Thank you.
Thank you. Thank you. Yeah, that's a very important point, and I think one of the issues that we're encountering as the technology becomes more and more prevalent, particularly using the mobile technology, mobile phones. When I remember discussing this with some of the people in Central Asia, that the youth were saying that this technology has enabled them to see how the rest of the world lives and what they can't have. And it has also kind of served as a device that's dividing the families, because the older generation is not savvy and they don't want to engage with this mobile technology, just like the youths are. And it's kind of creating a broader gap between the parents and the children, and plus the distress that comes in recognizing some of the challenges now that they face that they cannot address as readily because of the lack of resources. Yeah, yeah. So I think that we're coming to the top of the hour now, and I was going to give the panelists an opportunity to make very quick remarks or comments if you have before we wind down the webinar. Sido, do you have any last comments that you'd like to make?
Thanks. So just to say thank you again for the opportunity to participate, and it's amazing turnout, and thank you to everyone who joined. But just to reiterate that whole of society approach, I think we need to shift from thinking that mental health is a health issue to thinking about it as a societal issue. And we address some of the things like parenting, like what Murad was talking about, the challenges that married women are facing. These are societal issues. And those psychosocial risk factors, poverty, access to education, climate issues, all of that needs to be addressed if we're going to be holistically approaching mental health and finding contextualized solutions. And I'll end it at that. Thank you, Zol.
Thank you so much. So I wanted to thank the panelists for making time and bringing your expertise and your knowledge to share with the rest of the world. I think it's so important that you guys are kind of powerhouses of information and have been thinking about these issues for a long time. And I think it's so important that you have been sharing some of your thoughts and ideas and challenges and opportunities that we face in the realm of mental well-being in the communities that we serve. So thank you so much for taking the time. We really appreciate that very much. Wanted to thank all the participants for sticking through to the end of the webinar. Obviously, you're finding it interesting. I see there are a lot of comments coming through, and we will try and get you some of the answers that we haven't been able to address some of your questions. We will go through the question answer and provide it to the panelists for some responses for you, and over a due period of time, we'll share that back with you. There are a lot of questions about certification. And as I mentioned, and as Gloria mentioned at the outset, that we will make certificates available for those that need it. You need to communicate to us to let you know you need, and usually it takes about 2 weeks. So with that, I'm going to say thank you very much, and I'm going to pass it now on to Gloria. Um, First of all, thanking her for the logistics behind getting this webinar organized, which is very well thought out and executed. So thank you, Gloria. Over to you.
Thank you very much, Zul. But before we end, I think Murad also would love to give his final remarks. Uh,
Yeah, from the suicide prevention point of view, I just want to emphasize that although it's a very complex issue, and not something that is that easy to address, it's very important to remember as individuals that the first line of defense against suicide is our family, friends, and work colleagues. So no matter how many policies and strategies and so on we come up with, the first line of defense is always family, because we know the person very closely, close friends and work colleagues. And the second point I want to make is the number one suicide prevention strategy. There are lots and lots of things that go into a prevention strategy. The number one suicide prevention strategy is connectedness. All suicides happen in isolation. People kill themselves because they have completely lost hope, and they do it in isolation. So anyone you find is not the usual self, reach out to them. Any friend you have not been in contact with, reach out to them. Keep in contact. If you've had differences, try and overcome that. Connect with people. The more people are connected, the less chances are that they will become psychologically ill or they think of ending their lives.
Yeah,
So I
thank you,
just want
Murad.
to make that point.
Yeah, it's a very important point, and I think loneliness is really been recognized as being one of the big drivers for mental ill health. And there have been ministries now created in the UK, Ministry of Loneliness, to kind of deal with exactly that issue. I think it's so important that we do that. And as a nuance, I think I also want to make a point that this connectedness doesn't mean how many friends you have on Facebook. That's not the kind of connectedness we're talking about. I think Murad would agree that we're talking about personal connectedness, person to person type of a relationship that is so important. And we are losing this partly because of the technology. We are kind of shifting towards friends that are online. That might not be of as much help when the crisis hits and when we want to mitigate effects. So I think that we're there, unless Chido has any final comments. I'll give you back to Gloria.